So we change gears now and go to sickle cell disease and menstrual issues and gynecologic problems. And to present this issue is Dr. Kim Smith-Whitley. And Kim is the director of the Comprehensive Sickle Cell Center and clinical director division of hematology at the Children's Hospital of Philadelphia. She has a vast range of experience in sickle cell disease, and I can guarantee you this will be an excellent and superb presentation. Thank you.
Thank you for that nice introduction. We are going to switch gears a little bit. I'm pleased to speak with you on the issue of sickle cell disease, gynecologic, and menstrual issues. It's well known in this audience that sickle cell disease is a group of inherited hemoglobinopathies in which sickle hemoglobin is predominant. We know that it's associated not only with a hemolytic anemia, but with vaso-occlusion, primarily due to endothelial damage leading to vasculopathy. Women with sickle cell disease have been told often that the frequency of painful episodes, acute chest syndrome, can increase during pregnancy. And unfortunately, sometimes the interpretation is that women with sickle cell disease should not become pregnant. However, we know that there is confusion regarding contraception counseling for women with sickle cell disease, and that's what I hope to discuss this morning. We know that it's important to give individuals who are sexually active and not wishing to become pregnant access to family planning programs. And we're going to talk later this morning about studies that describe what the access to these family counseling services are for women with sickle cell disease. Unfortunately, because of some early studies in the 60s that we'll talk about, where it was suggested that oral contraceptions could lead to thrombotic complications in women with sickle cell disease, there are a wide variety of recommendations suggested in published literature and unfortunately on the internet about whether or not to use oral contraceptives in women with sickle cell. Despite the concerns regarding oral contraception in the late 1960s, there were case reports in the literature that suggested that some type of oral contraception may actually benefit women with sickle cell disease by decreasing painful episodes. So in the context of the theoretical risk of increase in thrombotic complications, we also had to balance that with a decrease in painful episodes during some women that were exposed to oral contraceptives. So why is this issue important? This issue is important because I believe strongly that women with sickle cell disease who are sexually active and do not wish to become pregnant should have other options other than surgical sterilization. And I think that we need to be clear with our recommendations regarding OCPs in women with sickle cell disease. The other reason it's so important is we now have a drug, hydroxyurea, that can decrease acute chest and painful episodes in all individuals with sickle cell disease. We often counsel our patients before starting hydroxyurea therapy about the teratogenic effects of hydroxyurea and strongly encourage contraception use during hydroxyurea therapy. And it's important for us as hematologists to know when to refer to an OBGYN and to know what to advise these women to take while they are initiating hydroxyurea therapy. So we'll talk about what's known in the literature about estrogen-containing OCPs or combined hormonal contraceptive agents, progesterone-only compounds. And then we'll hopefully have a good discussion about acute pain in the menstrual cycle in women with sickle cell disease and what we know about the association between pain and menstruation in young women with sickle cell. And then what the availability of OCPs are for women and girls with sickle cell disease. Are individuals with sickle cell disease recommended OCPs? Are they prescribed? If they're prescribed, do they take them? Just what do we know? And there are a couple of epidemiologic studies that we'll talk about at the end of this presentation. So one of the things that I really wanted to emphasize was what started this whole controversy. And there are several case reports in the literature by Dunn and Haynes in the mid to late 60s that report women with sickle cell disease on OCPs who have had pulmonary complications. And because of these concerns, it generated a lot of controversy. And I know this doesn't project well, but I want to just briefly read this. These are two cases noted of young women, one 26-year-old, one 27-year-old, one with the SC type of sickle cell disease and one with the SS type of sickle cell disease, that during their oral contraception therapy, they actually developed pulmonary complications. And the pulmonary complications they described were fever, chest pain, and an acute infiltrate on chest x-ray. Many of you in this audience know that Sam Sharash coined a term, acute chest syndrome, to describe a pneumonia-like illness in individuals with sickle cell disease. Unfortunately, his description came after these case reports. So it makes you wonder whether these very well-meaning but observant physicians were actually just describing acute chest, because there were also not any reports of DVTs in these original 3 cases in the literature about pulmonary complications with the use of OCPs. Unfortunately, because of this controversy, we are still seeing issues on the internet where there's not accurate labeling on the oral contraceptions that are offered to women with sickle cell disease, or there's a belief by the hematologist or OBGYN that sickle cell disease is a contraindication for OCPs. And this is just an example of one of these websites that says the pill is not recommended for women who have blood clots, stroke, liver disease, and if you go down to the almost next to last line, sickle cell disease is listed there. So what do we know about sickle cell disease and estrogen-containing oral contraception? Well, we know that there are several studies in the literature that address the use of either high-dose estrogen, low-dose estrogen, hormonal contraception in women with sickle cell disease, but these studies, unfortunately, have some limitations. There, of course, as I mentioned already, there are varying doses of estrogen that are used. There are different sickle cell phenotypes that are described in these studies, and as most of us in this audience know, even though SS might be the more common sickle cell phenotype or genotype, epidemiologically, not all those patients always have the most severe complications. And the SC type, usually in about 25% of our sickle cell patients, even though that's generally described as the lower morbidity and mortality group, that they can have significant complications too. But to put those two phenotypes in the same study may be problematic, because you really cannot reach the same conclusions about the sickle cell population in a whole when that's done. Unfortunately, there are also varying follow-up periods, some as short as 3 months and some as nicely long as 2 years. But many of these studies, despite the long follow-up, have a lack of control groups. And I really think that it's important when you're talking about thrombosis complications to have a general population of African American women, particularly in the US studies, to be a control group. Despite all of those limitations, I did really want to mention 4 important studies in the literature. The first randomized controlled trial was actually reported by Letcher et al. In 1981, where he prospectively evaluated 31 women who were on high-dose estrogen and followed them for at least 12 months. There were 70 patient years of follow-up in this study. For thrombotic complications and painful episodes. And although he did not see any thrombotic complications in this group of 31 women, there was one woman who had a very impressive increase in painful episodes during the course of that study. He was so intrigued by this study and these outcomes that he actually broadened his study group, reported on it again in '86 on 71 women with 276 years of patient follow-up, again not showing any thrombotic complications, but again, reporting on a very small subpopulation of women that had increased pain. Really, this was not further explored for almost a decade in the literature. But there was a group in the UK, Howard et al., in 1993, that reported on a group of 67 women with 148 years of patient follow-up on the use of estrogen-containing oral contraception. And even though it was a retrospective cohort, it was a sizable study. And unfortunately, not only did he show an increased rate of pain in a group of women taking oral contraception containing estrogen, but he also reported 2 DVTs. And these, and going back and even in the discussion section of this published article, the authors were actually concerned about the fact that they had not used a control group and wondered whether or not they were overestimating something that was not unique to the women having sickle cell disease. So they recommended that further research was indicated. There is a very nice study from Panama by Diabud that was published in 1997 that I would like to talk about in a little bit more detail in the next coming slides when we're talking about progesterone as well. What can we say about the literature on women with sickle cell disease where estrogen-containing oral contraception is used? That we really haven't seen thrombotic complications when good randomized clinical trials are used. When you look at prospective studies and retrospective studies in which control groups have not been utilized, then even the low rate of DVTs reported in those studies need to be considered with some with some skepticism about whether or not that was sickle cell disease related or not. However, despite the lack of good published literature documenting thrombotic complications, we still see sickle cell disease listed as a contraindication on non-US labeling for OCP use. And even though the WHO has categorized combined hormonal contraceptives as being in a classification where the benefits of using the drug far outweigh the risk, we still see there's hesitancy in our community for using combined OCPs. What do we know about progesterone only? And this is really an intriguing story in the literature, because really in 1967, there's a first case report of a woman who was receiving progesterone only for other reasons unrelated to contraception with sickle cell disease, where she reported a decrease in painful episodes so much that the investigators looked at hemoglobin and fetal hemoglobin levels pre-therapy and post-therapy in this woman and found that fetal hemoglobin and hemoglobin values were increased in this young woman who was on progesterone. This was followed up by a case report in 1971 by a 17-year-old who was started on medroxyprogesterone, DMPA, for actually dysfunctional uterine bleeding. And that young woman not only went on to have improvement with that complication, but had fewer sickle cell disease-related complications as well. When we're looking at the literature on progesterone-only compounds, unfortunately, we're faced with some of the same limitations, where different sickle cell phenotypes are studied within one prospective cohort. There are varying lengths of follow-up periods, and again, the lack of control groups, but still enough to really talk about for the purposes of our discussion this morning. There was an early report in 1972, actually that included males taking testosterone as well as females on progesterone. It was a nicely designed study. It was a randomized trial with crossover and a washout period. And both in the progesterone and testosterone groups, there was a decrease in painful episodes in 80% of the study population. Unfortunately, that study did not look at hemoglobin and hemoglobin F concentrations. However, a Jamaican report by de Cuellar in 1982 in which Depo-Provera was used in 25 women with sickle cell disease, they did see decreased pain, and an increase in hemoglobin and hemoglobin F. Now, I want to stop here by saying that the increase in fetal hemoglobin is truly intriguing. And there are studies by Jung where he has looked to see if this phenomenon is related to erythrocyte membrane stabilization, which did not prove to be the case. But a recent 2004 report suggesting that GATA1 in erythroid cells may be the reason, this increase in GATA1 activity, for the increase in fetal hemoglobin when progesterone is used. The increase in hemoglobin values may be related to the decrease in menstrual bleeding in this group of women, but that really hasn't been explored because control groups weren't utilized in these studies. Shifting gears a little bit, there was a study in Nigeria on 25 women with the SS-only type of sickle cell disease using Norplant. And they found that there was no difference in fetal hemoglobin in that group of women. And unfortunately, they didn't study painful episodes. But it was noted that there were no hematologic parameter changes. Again, the study by Diaboud comes up where there was randomization between progesterone-only, estrogen, and surgical sterilization, and I'm going to talk about that study in a little bit more detail in the next slides. And following that, in the late 90s and in 2001, Brazilian studies looking at Uniplant, small studies but all prospective, and they reported that there were no hospitalizations for pain in the first study and variation in fetal hemoglobin in the second study, but not in a statistically significant fashion. So finally, I really want to emphasize a nicely designed study by Diaboud that was published in 1998 on the effect of Depo-Provera, microgynon, and pay-for-crisis in women with sickle cell disease, SS type. And when you look at this, it's a prospective study. It was a long study. He looked at over 12 months, one group of women, 13, that took combined oral contraceptives, another group of 14 women that were on depomedroxyprogesterone only injectable, and then a group of women, 16, that opted for surgical sterilization. This study was done in Panama, and originally the authors said that this was a randomized control trial, but we really have to, I think, rethink that, and it's probably more based on assignment. So I'm not really sure that this was truly a randomized study where surgical sterilization was used. So you had to have sickle cell disease SS type, and you had to have had experienced pain in the last month before enrolling in the study. And I do believe that these results are quite impressive, in that when you look at the variation in pain frequency in these three study groups, this is the group that received the medroxyprogesterone. This is the group that received the oral contraception. And this is the quote-unquote control group with surgical sterilization. And you can see that over the course of these 12 months, that pain frequency decreased 50% in the surgically sterilized group, 45.5% in the women receiving the oral contraception, and 50% initially in the initial trimester, but all the way down to less than 30% by the end of the 12-month period for the women that were taking the medroxyprogesterone. So that really gives us a nice overview of what we know about estrogen-containing and progesterone-only compounds from published literature. But what do we really do in practice? And fortunately, Dr. James introduced the CDC medical eligibility criteria to me, and so I have to thank Dr. James for sharing these slides. Because we know now that the CDC adopted the World Health Organization's classification screen levels for oral contraception or contraception in general in 2004. And primarily what we have adopted now are the WHO criteria that again emphasize that combined hormonal contraception for women with sickle cell disease is very advantageous, and the advantages outweigh the risk of associated with estrogen-containing contraception. However, we should think more carefully about women with sickle cell disease who have had documented stroke or a line-associated clot, and it may be that progesterone-only compounds are best used in that group of women. Additionally, the CDC does not think that the level 2 criteria is appropriate for progesterone only, and basically says that progesterone only methods offer no additional risk to women with sickle cell disease. The copper IUD has been reported with increased menstrual bleeding, as you know, in the general population, and there's a concern about copper IUDs in women with sickle cell disease as well. But there are other devices such as progesterone or levonorgestrel IUDs where they may not be as many bleeding risk, and this is actually no restriction for the use of this method in women with sickle cell disease. And of course, there's no contraindication or restriction for barrier methods, female sterilization or male sterilization. So essentially, when someone comes, and I'm going to go back one slide, to the office and is stating to you, a young woman, that she's interested in starting hydroxyurea therapy, and that she's heard that hydroxyurea can be associated with teratogenic effects if she should become pregnant in the first trimester of pregnancy, and she's interested in some type of contraception to use with her hydroxyurea therapy. I will tell you, in my institution, most of these patients are managed along with the adolescent gynecology team or with referral to an OBGYN, so that we are not starting contraceptions in the contraceptive methods in the hematology clinic. We really think that they should be counseled by an OBGYN. However, our OBGYNs that primarily work with us have been really intrigued by the success of the levonorgestrel IUD in these young women with sickle cell disease, and it seems to be very well tolerated. They're pleased with not having to remember on a daily basis to take yet another additional pill, as they described to me. And despite that, many of them that do not opt for this method opt for medroxyprogesterone compounds. And I think that that is very advantageous for the use in women with sickle cell disease. However, I will tell you that there have been no long-term studies on the bone health in women with sickle cell disease who have been on hormone-containing contraception. So this needs to be investigated further. So is pain associated with the menstrual cycle in women with sickle cell disease? And I can't say a loud yes, but surely it's suggested by the results of these two studies. The first in 1985 by Roland Scott at Howard and colleague, where they looked at 52 women with sickle cell disease with all different phenotypes, and found that about a third reported acute painful episodes associated with their periods. Jung repeated this study in 2002 in 42 women, and found, just with a slightly higher frequency, that pain was associated with their periods. And in the Jung trial, they actually found that it wasn't just during the phase of menstrual bleeding, but it was premenstrual as well as mid-cycle pain. So you can see that if sickle cell pain may be related in a small group of women to their menstrual cycle, and that we know that progesterone may decrease pain in women with sickle cell disease, that those women may be particularly good candidates for progesterone-only containing compounds. And we also have shown through our review of the literature this morning that there's really not a documented risk of increased thrombotic complications in women with sickle cell disease exposed to hormonal contraception. So if we know this information, then really what is the use of hormonal contraception and unwanted pregnancies in this patient population, to try to give us a sense of how frequently women with sickle cell disease are offered contraception, what type of contraception they're offered, and whether or not they're adherent to what they're prescribed. And there are really 4 studies in the literature that address this issue epidemiologically. The first published in 1984 on 52 women with sickle cell disease. They actually used a control group, found that OCP use was the most common preferred method for contraception in this group of women, and that there were still some unwanted or unplanned pregnancies in this group, but in this study it was no different than in the control group, and that there was a 60% pregnancy rate in that study. There is also the UK study that I mentioned earlier in 1993 on 164 women with sickle cell disease, where 45% of them, when the 91% used contraception, and of that group, 45% chose combined hormonal contraception, progesterone only containing, and 20% IUD and almost 20%, and depomedroxyprogesterone about 17%. However, there was still a high rate of pregnancy, unplanned pregnancy, in that group of women with sickle cell disease. However, there was no control group utilized in that study. There's a Jamaican study in 2009 that looked at a similar sized group of women with sickle cell disease, 132, where 48% used contraception, mainly the barrier method, but 28% used medroxyprogesterone and 22% OCPs. There was an interesting note in the study that in that group of women with sickle cell disease, there were 25% who had experienced miscarriages. And I think that that probably requires further investigation. And finally, I'll end with this large Nigerian study with 307 participants, 15% oral contraception use. And I think that that is, even to these authors, surprisingly low in their population. What do we know about the US? Well, there is an interesting study, hormonal contraception use in pregnancy in adolescents with sickle cell disease, an analysis of Michigan Medicaid claims data that was published this year. And the study goal was to use insurance claims data to assess rates and types of contraception use, the frequency of pregnancy, DVTs, and osteopenia among female adolescents and young adults with sickle cell disease. They identified 250 women with sickle cell disease in their geographic region during a 4-year period between 2000 and 2003. And they found that only 20 patients had outpatient claims for contraception use. Now, it could be that these young women were utilizing Planned Parenthood services or services unrelated to Medicaid. But what is really interesting in this study is that even in the group that became pregnant, by 12 weeks postpartum, less than 10 of the 55 patients had really sought contraception counseling again. So it really calls to mind, one, whether or not women with sickle cell disease are being offered hormone-containing contraception. If they are they adherent to that therapy? And then if this is happening in the US, then really what's happening globally with women living with sickle cell disease? So this is quite concerning. To summarize what we've talked about this morning, there is a possible underusage or underprescribing of hormonal contraception in girls and women with sickle cell disease. There's data supporting that a certain population of women with sickle cell disease experience acute pain around their menstrual cycles, and I think that this is really important to emphasize because this subgroup may be really benefited by using progesterone only containing compounds, particularly when used with hydroxyurea therapy. There are no studies actually that suggest that combined hormonal contraception is associated with an increased frequency of thrombotic complications in women with sickle cell disease. And that women with sickle cell disease who are sexually active and do not wish to become pregnant should be offered these agents. Medroxyprogesterone is safe in women with sickle cell disease and may decrease acute pain episodes. And then when we are offering combined oral contraception, I think that particularly since we're thinking about this globally, we should really consider recommending low-dose estrogen-containing compounds until we really have the research to support using higher doses, as there's still some concern with higher doses about thrombotic complications. And my recommendation is research, research, and research. There are so many unanswered questions around hormonal contraception and women with sickle cell disease. And there's obviously a problem that we need to address globally to make sure that women with sickle cell disease are offered good contraception counseling. So I think that we really need to study further this theoretical risk of DVTs, PEs in women with sickle cell disease on combined hormonal contraception. We really need to further investigate hematologically what is the mechanism for the benefit of decreased pain in women taking the progesterone-only compounds and whether or not fetal hemoglobin really does play a role. And then I really think that there's a lack of data in the literature on the bone health of women with sickle cell disease who are on long-term contraceptive therapy. And I think we really need to understand what we're offering women in the community. So surveys need to be done for hematologists and OBGYNs to see what their recommendations are for this patient population. Thank you.
This talk is open for questions. Please identify yourself.
Hi, Alice Cohen from Newark, Beth Israel in New Jersey. Thank you. I think this is a tremendous area of concern. We have a large adult sickle cell and pediatric program at our hospital, and just reviewing what's going on, many of these young women and older women are not even seeing gynecologists to even have the conversation, so I think it's a big deal. We're trying to address that by creating medical homes for our sickle cell patients, so it's not only about pain and hydroxyurea, but other issues related. But my question really relates to the IUD. And there are anecdotal reports, and we've seen in our institution, unfortunately, a death from IUD with pelvic abscess. And we've seen placement of IUD because of the concern about using oral contraceptives. And I wondered if you could comment on that, because for me, I think it's a bigger concern in these patients who are immunosuppressed and the role of IUD versus oral contraception.
So I think that's an excellent point and a very good question. As you know, most of the infection-related complications in women with sickle cell disease are in the early periods of life around strep pneumo. But we do see staph infections in individuals living with sickle cell disease later in life. So I think your point is well taken, and that definitely requires further investigation, particularly when using IUDs. Fortunately, in the small N that I follow, we have not seen that increased risk and infectious complications. And I really wonder what OBGYNs in general see with use of IUDs in the general population as well. Thank you.
Hi, Susan Kloster from USC. Hi, Kim. That was great. I actually had the same question about the IUD, so you answered that. My other question was, do you have any information about using NuvaRing?
I don't.
Okay, because that's actually a good option if you don't remember to take your pill.
Right, and I could not find anything in a nice prospective study. I think there's a case report, and I see Dr. Dietrich going to the microphone. Do you have something to add to this? And Dr. James, too. Wow, you got everybody up here with that question.
I'll let Andy answer first.
You first. I think we have two OBGYNs here competing to answer the IUD question.
Okay, so first of all, with regard to IUD use, there are a lot of studies. We have many, many decades now of studies with regard to IUD use. And while some of the older IUD monofilaments and things like that were not as ideal. The way that these materials are made more inertly nowadays, they're very safe. They do not seem to increase the risk of pelvic inflammatory disease. They may be safely used in nulliparous women, including teenagers. And so really kind of your cutoff or your indication is as long as the uterus is big enough and you can place it, it's a very safe device to use. In addition, the World Health Organization, it's interesting, I was invited to a meeting to participate in that discussion about whether or not an IUD should be removed and that you should screen every teenager for chlamydia and gonorrhea prior to its insertion. And what the conclusion was to that was, in fact, if you see mucopurulent discharge at the time that you are going to insert an IUD, you shouldn't insert it and you should first screen. Or if you don't see that infection initially, it's pretty safe as long as you've ruled out pregnancy and you can be reasonably assured that they are not pregnant, that you can place the IUD. So it's just a matter of making sure that the IUD is placed correctly and doesn't seem to be associated with those increased infectious risks.
Thank you.
Did you have a comment
Yeah,
about NuvaRing?
No,
No? Okay.
I just wanted to underscore the fact that with modern IUDs, the rate of infection is no greater in women with or without. The rate of pelvic infection is no higher with or without the IUD. So we should not be constrained in using it for contraceptives. No increased risk with the modern IUD. So we should not be constrained in using it in our patients. And the NuvaRing is not an intrauterine device. It's an intravaginal device. It's a combined hormonal contraceptive, and it has the associated risks that a combined hormonal pill does. It's estrogen containing. And we'll cover some of that in the next talk.
I think we have a question in the back first.
I'm Saud Abu Harbish from Saudi Arabia. I have actually plenty of sickle cell anemia patients. Maybe we got more than 1,000 sickle cell in our clinic. I have just simple question, and it's the question which I hear it almost every week from my patient. What will be the best way that you will advise them if they are going to be in hydroxyurea for young female patient in hydroxyurea? Which sort of contraceptive? Do you recommend it? You don't recommend it? And what type of contraception?
So for the use of hydroxyurea therapy in individuals with sickle cell disease, in the pediatric population, since there are no prospective randomized trials, we have adopted the studies from the adult, the MESH studies. And so for individuals with sickle cell disease who have frequent pain episodes or acute chest syndrome, we use those as indications for the initiation of hydroxyurea therapy in our group of patients as well. And in fact, when you think of the just to give you an example, we have 1,000 patients that we follow with sickle cell disease, about 62 to 63% of whom have the SS type of sickle cell disease. And now we have over, between our main institution and our sister institution, have well over 160 children with sickle cell disease on hydroxyurea therapy. And that's probably a lower number because we have many children on transfusion therapy for stroke prevention as well. So we are definitely using it, and we're using the adult criteria as indication.
And for adults, if they are in hydroxyurea, for adult female patient who's married and they are asking for some sort of contraceptive
that's a very good question.
In combination with the hydroxyurea.
So what we do is we use our OBGYN colleagues, and so I can only tell you what my OBGYN colleagues that I work with in this patient population do, because I really could not find anything in published literature, and if there are other people who have similar experiences, please share. But what we tend to do is when they're interested in becoming pregnant, we actually briefly we stopped the hydroxyurea therapy, talking to the woman about what the indication was for hydroxyurea and whether or not a brief period of transfusion therapy would be the replacement while they're off hydroxyurea therapy, or if we're just going to stop them. And then I will tell you that my OBGYN colleagues, with the help of adult hematologists, have been restarting hydroxyurea in the last trimester, where the risk is much lower.
Actually, I think you missed my point.
Oh.
My question is, what is the contraceptive device or method which you will advise young female patient who is in hydroxyurea?
Oh, I'm sorry, I mentioned that earlier. Most of them start progesterone-only containing compounds. So they either have used the IUD or used medroxyprogesterone, either in the depot form.
Okay, thank you.
You're welcome, sorry. Yes.
Abir Abuyabis from Central Georgia Cancer Care. I have an adolescent sickle cell clinic, and I have seen a very frequently adolescent patients, females who come with menorrhagia, sickle cell patients. And I usually screen them like a regular person, and I have seen increased incidence of dysfibrinogenemia. Their fibrinogen antigens are normal, but they really, they have dysfibrinogenemia. And I tried to search the literature. I didn't find anything about that, if it's really related to sickle cell or this is just part of like the general population. I have been treating them with like Amicar starting the first 2 days of their cycles. And but the problem I'm faced with is some of those patients who are recurrent crises, who have like ports, who have already had multiple like clotted ports or DVTs which are provoked, 2 weeks crisis, they come with a DVT or, excess of the ports. So I really don't know how to advise them, because whether I'm gonna do like hormonal treatment or I'm gonna do Amicar, I'm always like, and their hemoglobin definitely drops significantly, during their cycle. So I don't know if you have any.
I was hoping I wasn't going to get this question. Because that is the clinical scenario that really worries me the most, and I don't know the right answer. I will tell you what we have done is that we have used progesterone-only containing compounds in that group of women. We also have had women come in from outside institutions, and I know this is a different scenario, that are on IVF cycles because they're pre-transplant and they are doing oocyte preservation that have similar syndromes. And so what I have seen some people do is they come on low-dose agents for anticoagulation in the context for their brief period of either going through oocyte preservation. But with dysmenorrhea, obviously that's not something that you don't want to introduce. And after they have that initial burst of high-dose estrogen-containing compounds for the acute menorrhagia, we try to rapidly transition them over to other methods to control their menstrual cycle, and we are using the progesterone only. I was so hoping I wouldn't get that.
David Duguid, Columbia University College of Physicians and Surgeons. Kim, thank you for shining some light on a topic that really needs to be addressed to a much greater extent. I actually have a slightly different question, and that relates to hydroxyurea and teratogenicity. I've spent a lot of time looking for evidence of teratogenicity, and I certainly understand the physiology of why it should happen. I've never seen it, and I can't find anyone who has either.
I can't find it in the literature either, but unfortunately it's on the label, and so that's, I think, why we are so hypervigilant about it.
Thanks.
Thank you. Andy.
And James?
So I'll comment on the hydroxyurea question. I know that the National Heart, Lung, and Blood Institute has convened a committee to develop guidelines for primary care in sickle cell disease, and wrestled with this question a great deal. What guidance should NHLBI expert panel provide to practicing physicians around hydroxyurea in the periconceptional period. And these are not final, these haven't been published, these haven't been peer-reviewed, but the working draft will be, because there are no data that would demonstrate an increased risk of teratogenicity in humans. There is some evidence in animals, and perhaps it can be extrapolated from increased potential carcinogenesis. Although we also have to recognize that sickle cell disease itself is potentially harmful to embryos and fetuses. But in the absence of any other data suggesting that there's harm in humans, that there won't be proscriptive guidance in terms of withholding it in the periconceptional period, but that the recommendation will still be that it be deferred in pregnancy. Although I think that's without good evidence that it be withheld in pregnancy. So the working draft says continue it until pregnancy, withhold it in pregnancy, although there are no good evidence to do that. And I think that with baby hug data showing safety in infants, I think that there's more and more reason to get it started later in pregnancy, as your institution is doing.
Thank you. Do we have time for one more?
Yeah, one last
Okay.
question.
Okay. Pat Adams-Graves from Memphis. I sat on the MISH Data Monitoring Safety Board for 11 years, and I believe that Dr. Ballas and Clint Joyner, I don't know if they're in here, looked at
Pregnancy
that data
outcomes, they did.
to see if there was any teratogenicity and et cetera. And there was just nothing. Looked at the men, and of course, mama's baby, daddy's maybe. But still, they were on hydroxyurea when they, quote, fathered a child. So there's very little evidence, even though the focus and the aim of the MISH study was not to look at that. There was still the pregnancies in the safety profile in the extension study. And I believe there's one paper out that's almost saying hydroxyurea should be safe in pregnancy in sickle cell individuals. But that's somewhere that you could either contact Dr. Ballas. I think Dr. Ballas is still a professor emeritus at Jefferson.
He
And
is.
Clint Joyner at the University of Cincinnati, who is a neonatologist who also sat on that committee, could answer some of your questions about, even though, you know, it's nothing major that's been published, I think one article, but they still can talk to you about what was seen in that, under that.
Thank you,
group of
Dr.
patients.
Adams-Graves. And I have been reminded by the organizers that I forgot to say that I have no disclosures related to this talk. So thank you very much.